Okay, and we still got a few more people coming in, but we are going to get started 12 o'clock, just to be mindful of time. And I just want to welcome everyone to our training on the needs of transgender and gender diverse people in our healthcare system. Today, Dr. Stéphanie Madill and Elijah Gatin will discuss their research, which investigated the experiences of trans and gender diverse people across Saskatchewan having access to healthcare. My name is Catherine Yerkew, and I am the Community Services Lead for Manitoba and Saskatchewan with the Leukemia and Lymphoma Society of Canada. Since there are so many of you in the audience, we invite you to type your questions and comments in the question box of your Zoom webinar panel throughout the presentation. Please use your Q&A box for the questions. An LLSC staff member will monitor the questions. I will read some of the questions aloud at the end of the presentation during the Q&A period. Today's training will be recorded, therefore you can listen to it again on our continuing education platform. Before we begin our main presentation, I would like to share our mission and highlight some resources that might be helpful for you and the patients and caregivers you are supporting. Next slide, please. At the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We listen attentively and with compassion to the challenges of our community. We help them get organized to manage and take charge of their care, and we can identify services that would be beneficial for them. Visit bloodcancers.ca to find the contact information of the Community Services Lead in your area. Next slide, please. One of the most popular items for healthcare professionals are our tear pads. They have been tested with blood cancer survivors and agree it would be a good first tool to have, as it was not too overwhelming. Do not hesitate to refer patients and family as early as possible after diagnosis. We can help them prepare for what they identified as the most difficult step of their blood cancer experience, announcing their diagnosis to their family. Next slide, please. We offer a continuing education program you can join for free of charge. You can register to one or more trainings that you can do at your own pace and receive an electronic certificate of participation. There are 1,000 healthcare providers currently using our platform, with 40 trainings available in English and in French. There are trainings on blood cancer, palliative care, and psychosocial aspects of cancer. We continually add new trainings monthly. Be sure to stay up to date with our latest training. The LLSC is passionate about supporting healthcare providers. The continuing education platform, designed for the blood cancer community, has proven to be highly valuable in providing essential education. Extending our commitment to inclusivity, today's webcast is part of our broader initiative to enhance healthcare practices across communities. In recognition of the broader applicability of tools discussed today, the LLSC wanted to extend our reach of this webcast to a wider audience. This webcast will equip healthcare providers from various disciplines with tools and knowledge essential for effective collaboration with the trans and gender diverse community. By fostering a better understanding and promoting inclusivity, we believe that coming together at all levels is crucial to providing optimal care. Next slide, please. We also offer free materials to healthcare providers. By visiting our website, you can place an order for materials that will be sent directly to your cancer center or clinic. Materials that can be ordered include disease booklets, service posters, palm cards, and more. Next slide, please. Also available online are all of our educational tools and resources vetted by experts for all the main types of blood cancer. Our material is available in multifaceted formats to address the variety of needs and preferences. These include digital disease books, fact sheets, podcast episodes, animated video, and webcast recordings. Next slide, please. Emotional and practical support is a priority for the LLSC. We offer programs that can help the blood cancer community connect. We offer a peer support program where people can connect one-on-one with a peer volunteer and virtual support groups. Visit our website at www.bloodcancers.ca to reach out to the Community Services Lead in your region for more details. Next slide, please. It is now time to introduce our speakers today, Dr. Stéphanie Madill and Elijah Gatin. Dr. Madill, she, her, is an assistant professor at the School of Rehabilitation Science, University of Saskatchewan. She completed her Bachelor of Science in Physical Therapy at the University of Alberta, and then worked in diverse practices from inpatient rehab to long-term care, to state schools for the severely handicapped, to maximum security prisons. She completed her Master's in Science and Ph.D. in Rehabilitation Science at Queen's University and a postdoctoral fellowship at Montréal University. Her research interests have shifted from promoting health equity for people who are trans and gender diverse. Dr. Madill identifies as lesbian, queer, and disabled. She has been involved in queer activism since the early 1990s. Dr. Madill was invited by OUT Saskatoon and members of the trans community to co-lead the Trans Project with Dr. Megan Clark in 2018. Elijah Gatin, he, him, is joining us today. He is the Trans Health Navigator from TransSask. Over to you, Dr. Madill and Elijah.
Thanks, Catherine. I guess I'll start. So today we're going to be talking about the Trans Health Navigation Project of Saskatchewan. I'm Elijah Gatin. Stephanie will talk at some point here. And thank you everyone for coming. So we'll just get started. So in this space, what's shared here stays here, and what's learned here leaves here. So what I mean about that is that Stephanie and I will probably talk about our lived experience a little bit. And we want y'all to use that as connecting with us, but our stories shouldn't leave here. Those stories aren't for other people to tell. So any stories that we share about our lived experience, we'd like them to stay within the presentation. Anything that you learned from the content, you can share it, reach out to us, share it with anyone you think of. But again, please be respectful and don't share our lived experience. So I'm gonna jump right into it. Please bear with me. I have a bit of a cold, so you probably hear me cough or sniffle. We're gonna talk about the Trans Project. It's the Trans Research and Navigation Saskatchewan. It began before this, but we're going to talk about the thick of my work in this one. But from 2021 to 2022, it was a research project at the University of Saskatchewan in partnership with UR Pride in Regina and OUT Saskatoon in Saskatoon, which piloted 2 trans health navigators, me being one. I'm for Saskatoon in Northern Saskatchewan, and then my coworker who is a navigator for Regina and Southern Saskatchewan. So there's only 2 of us within the province. We support trans and gender diverse people in Saskatchewan, and it's been a very, very big success. We have lots of clients. Currently, we're no longer a part of the University of Saskatchewan. Our research project ended and our funding ended. So we're housed by TransSask, which is a by and for trans organization in Saskatchewan. So it is run by and employed by trans people and is a specific organization for transgender people. And we've had funding from a variety of sources. And this continues to be vital in demand service for the community. Our client loads have not changed at all. We're very, very busy. Anything to add, Stephanie? So what we do as trans health navigators, we help trans and gender diverse people access healthcare services, supports, and resources. So things like finding a family doctor for the basic healthcare needs, someone who's knowledgeable in and inclusive and safe for gender diverse people, and knowledgeable in gender affirming care, which can involve hormones, surgery, legal changes, all those sorts of things. We'll get a little bit more into that as we go. We assist with legal gender marker and name changes, which includes notary services. So at the beginning of the project, Ken and I noticed there was a huge barrier for legal name changes and people being able to access notary publics to do that. So notary publics with the help of Stephanie and Megan, which has been a big help for the community. We educate healthcare professionals on providing trans inclusive and transition related care through presentations and consultations. So what I'm doing with y'all right now, we do this with large groups like this and also smaller groups. It can include anywhere from social worker, nurses, doctors. I'm a medical office assistant. We've done it for the schools for medical office assistants and things like that as well. So what we're doing right now, we offer that as well. And then we answer questions and offer information to other supports and providers. When I say other supports, I usually mean family members, parents, guardians, anyone that's connected with trans people or working with trans people, or anyone that wants to learn more about working with trans people and providing safe and inclusive care. So a little bit further into what we help with. So we find inclusive doctors for various needs. I'm sure wherever everyone's from, we are all feeling the lack of family doctors within our provinces, that there's been a major strain on our healthcare services, and that it's been very difficult to access a family doctor for basic healthcare needs. But this gets more difficult for trans people because not every provider is safe to be treating a trans or gender diverse people, two-spirit trans or gender diverse people. We help our clients navigate referrals, help them track them down, see where they are on wait lists, help them figure out where they are on surgical lists and all those kinds of things. We connect people with accessing hormones. So there's all family doctors can provide gender affirming care, but most will choose to refer out to another doctor that has more knowledge or training. But our goal is to hopefully get more family doctors to provide gender affirming care to get rid of that barrier, and so that people don't have to see multiple doctors for something that they can see one doctor for. We help people access surgical pathways, advocacy in healthcare settings, preparing for healthcare appointments. We communicate with and among providers. We have a long list of providers that we're connected with that we work with and we love so much. Accessing mental health supports, legal and gender marker changes, finding resources, peer support, answering questions about healthcare, and so much more. The program project is directed towards trans and gender diverse people of all ages and all stages of their transition. So sometimes we'll get people that are youth that are as young as 9 and 10, and then people that are seniors as well. Parents that are looking to support their children a little bit better, family members, friends, teachers, healthcare providers, you name it. We're always excited to support anyone that's looking to support trans and gender diverse people more. So some of our biggest challenges in the Trans Health Navigation Project is a primary care bottleneck. There is a low amount of providers taking trans patients for transition-related care and general care needs. So if someone is being referred to a doctor that is a little bit more knowledgeable, that waitlist is looking around 12 to 18 months and still climbing. So most people are waiting about a year to 2 years for just an initial appointment to meet a doctor that might prescribe them hormones. So that is a huge barrier for our community. Lack of provider education. Like I said, all family doctors can prescribe HRT. When I say HRT, I mean hormone replacement therapy, but most will refer to specialists, which causes these extreme wait lists. Missing community support services. We need more community networks and nonprofits who offer services and help with healthcare access, funds, etc. We also need our governments to actually fund our nonprofit works, because anyone that works in a nonprofit is working their butt off, and we deserve some funding to continue our necessary work. So a small glimpse into the trans community and culture. We're a strong, close-knit community, as some people think, where it's a small community, but we're quite a large community, but we like to take care of each other. Our intersectionality and diversity, we come from all different walks of life, ages, backgrounds, cultures, everything. It's not just a group of people, one set of group of people that become trans, or that are trans, not become, sorry. Widespread sharing of negative and unsafe experiences with providers. We keep track of providers that our clients have had issues with and have faced transphobia with providers and clinics. So we like to keep note of that so that we aren't sending people to unsafe providers to further trauma. But in saying that, we also keep track of the really great providers. So if someone has had a really good experience, that's going to be a provider that we're going to share with our community and be like, go see this person. They're really amazing. They're going to respect your name and pronouns. They're going to, even if they're not legally changed. But word of mouth within our community spreads very quickly just to keep everyone safe. There's non-traditional relationships and families. A lot of the population of trans people don't have great relationships with families and things like that because of transphobia and lack of education and information. So we've built our own chosen families and support networks that help us thrive. So we do have a little bit more of a non-traditional dynamic with families and relationships. We share in a lot of trauma and suffering. A lot of things that I'm going to talk to y'all about is that things that have happened and that most trans people have experienced. These aren't just one-off things that people are experiencing. Word of mouth, access to info, so health transition and services. So before I started in this position, I actually navigated my transition by myself with word of mouth from the community, which was very great. But now that we have this service of navigation, it takes that labor off of our community, which means that myself and my coworker, we know the doctors, we know what their specialties are and things like that, so that we can take that labor off of our community so that people can focus on themselves and thrive and experience euphoria. Financial community support, GoFundMe is a very big, a big thing that you'll see within the trans community. A lot of our surgeries and things like that are not covered, so we go to the community for support, accessing surgery, hormones, and anything that we need. So there is a large support for financial things in the community. Love and support and happiness. I love being trans. I love being part of the community. I feel supported by most people that I know within the community, and I wouldn't change that for the world. I'm glad to be part of such a supportive, close community that takes care of each other. So what does being trans mean? This means when someone's gender identity is different than their sex assigned at birth. Being trans looks different for everyone. My experience is going to be totally different from someone else's, depending on our environments, our backgrounds, and exactly what we're looking to be our journey within our medical transition. Someone can realize that they're trans at any age. It does not diminish their transness. A lot of myths that we hear is that only youth come out as trans. That's not true. I didn't come out as trans until I was 28. So people will realize at their own pace, but that doesn't diminish any of their experience. And identities and labels can change over time, and that's not a bad thing. Some people will use they, them pronouns and think that they're non-binary, and that might change over time, but that just means that someone's growing and experiencing life, and yeah, change is good for the most part. We should be celebrating change. And this may or may not include medical transition or legal changes, and that's just as valid. There's a lot of different reasons for that. Financially, it's very expensive to access certain surgeries. Legal changes can be really expensive. And some people just don't want to access them out of safety. That can be something as well. We're not quite living in an environment where everyone can be out and proud as being trans. Being trans is not sad, bad, or tragic. The cis community has this idea that we live such tragic lives. And for the most part, we want to thrive. I'm working in my dream job. I have an amazing partner. I'm looking to start a family. I work with some of my closest friends. I think that my life is very fulfilled, and I'm enjoying it. So we don't live these sad, bad, and tragic lives. Some of us do, but a lot of that is because of environment, and what's going on in our world today. So I'm going to talk a little bit about sexual health. Trans people require health screenings for their body parts, regardless of gender identity or HRT status. So just because you don't know which words to use for people's body parts doesn't mean you can skip over exams. We're people, we still need these exams. 50% of trans men and trans masculine people do not receive annual pelvic exams. I know a lot of people that have been told that they do not need PAPs anymore because they're starting testosterone. This is not true. Even after someone's had a hysterectomy, if their cervix is still intact, you still have to give them a pap smear. So talk to your patients about those things. And up to 93.8% of trans men who have sex with men report to have a lack of adequate information about their sexual health. I don't have the stats for trans women or trans women, but there is also a big lack of screening for prostate cancer within that community. So a good way to have these conversations is to converse with your patients and ask them what words they like to use for their bodies or body parts, because a lot of people don't use medical or scientific terms, and use those terms that people are using for their own bodies. And if you're uncomfortable and noticeably uncomfortable, we're going to be uncomfortable. And that's when we're going to say, you know what, I don't want this exam. And be patient with your patients. If they say they say, you know what, I can't do this right now, say, okay, book an appointment when you can. Don't try to force people into exams that they're uncomfortable with. This is going to cause medical trauma. We don't want to do that. We want people to access our services so that, or access clinics so that they're actually getting the healthcare that they deserve. So asking about trans clients' bodies, a practice point, first ask yourself if it's nice to know or need to know. Some people get curious and they ask whatever question comes into their head. And that can be really unfair in a medical setting. This is something that's happened to me multiple times, is that doctors focusing on asking me invasive questions about my transition instead of focusing on what I'm coming into their clinic for. So if you're just curious about something, don't ask unless your patient has said, that's okay for you to ask. If it's not going in my chart, then try to avoid asking those questions because it might not be part of our care. Something that me and my coworker just found was an organ inventory. This is a checklist of organs and structures that is adaptable and expandable over time. It reports absence and presence and procedures that may affect or that those people might have access, and should be updated annually or as needed. And a little quote, in order to provide you with the best clinical care, it is important for me to know if you have certain body parts. Is it okay if we talk through a list of body parts and you can let me know whether you have these? If you use different words for parts of your body, please let me know. What we did was implement this in Planned Parenthood in Regina, and it has been so successful. They've attached it to their intake form so that a client can fill out their intake form and then fill out an organ inventory, so that when that piece of paper is given to that provider, they can look through it and they can be like, okay, I don't have to ask these set of questions because they've already told me this information. So instead of doing that work in person, you can, like with the organ inventory, you can do that on your intake form. And then once you get that client into an exam room, ask them what words work best for their body, for them and their body, and where they feel most affirmed. This also opens up you connecting with your patients and being transparent. no one is excited about going to a doctor's office or a clinic, and most people are nervous and are going to forget what to say. But if you're transparent and connect with that patient, those conversations can open, and then we'll be more comfortable into letting you know what we're experiencing and what we need your guidance with. So this is kind of a look at the organ inventory. You can see that there's a lot of procedures on there, and you can talk to Catherine, and I can forward this over if this is something that y'all would like to implement within your clinics, because it is very, very helpful. And not just helpful for the trans community, helpful for everyone. We're not just going through some of these procedures. There are cis people that are also going through these procedures. And instead of talking about it in person with a stranger, it can be easier just to write it down. So it's not something that's going to be just positive for the trans community. It's going to be positive for everyone. So something to think about within your clinic settings.
And I want to jump in here quickly before you zip on. You want to jump back, Eli? The first thing is that trans women who've had bottom surgery, they typically keep the prostate gland as sort of a keystone of the pelvic floor to prevent prolapse. And so even trans women who've had bottom surgery have a prostate, and so don't make the assumption that they don't. And then using this, it's a good way to then go in and plan your screening and do cancer screening according to the organs that people have, and not the sex or gender recorded at the top of the form. Okay, your turn.
Thanks, Stephanie. So I'm going to talk a little bit about trans broken arm syndrome. If you're cisgender, you might not have heard this before. This is commonly used within the gender diverse community. Most gender diverse people have experienced this when accessing anything medical. And what this is when healthcare providers assume all medical issues relate to being trans. So my experience with trans broken arm syndrome that I speak about is I accessed a fertility clinic with my partner. I wouldn't be carrying the child. I wouldn't be using any of my specimens, but that doctor decided to focus on me instead of my partner in that appointment, and asking me a lot of invasive questions about which surgeries I've had, which hormones I'm on, and things like that, instead of talking to us about what we were accessing this fertility clinic for, which had nothing to do with any of my body parts, which then ended in us not accessing that fertility clinic again and doing all of this labor ourselves without a specialist involved in this care, because I did not feel safe in that clinic whatsoever. It sucks. It sucks not being able to meet your medical needs. So we say that if you're just curious about something, please don't take up our appointment time just answering your own curiosity. We all have Google, we all have medical books. We can look that up ourselves. This includes discussing our trans status and HRT at unnecessary lengths. This happens quite a bit, even if people are accessing a clinic for a cold or something minor, or just a physical injury, that doctors and providers will get uncomfortable and talk about our hormones and our transition instead of treating what our complaint is when we're accessing those clinics. And this applies to mental health as well. Oftentimes, mental health providers will blame a lot of our mental health concerns on dysphoria, our environment around us, our trans status, and that's really not fair. A lot of people are experiencing the same things that cis people are experiencing outside of being trans. So we want to be focused on our complaints rather than what our identities are, which can be really and then if you're focusing on other things, our identity rather than our complaint, then that's a wasted appointment for us where we're not getting treated. So again, think before asking if it's need to know or nice to know. If you're just curious, don't ask the question. If it does nothing to do with our care, don't ask the question, don't make the comment, keep it to yourself. Reach out to a health navigator or your trans nonprofit, and maybe they can answer your questions for you, but don't put that labor on your patients. So a snapshot of trans inclusive care. It does not diminish, demean, or disempower identity and well-being of an individual. It enables safe service to be defined by those who receive the care. So not by the clinic itself or the providers within the clinic, but by the people that are receiving the care. If someone says that they're not feeling comfortable in your clinic, you're not allowed to tell them that they're wrong. If someone says that they're not comfortable in your clinic, ask them why and what you can do better. Don't demean or diminish our experiences, because again, that's what stops us from accessing our medical care and causes medical trauma and other health problems within our community, because we're not accessing providers as much as we should be because of the anxiety that we feel accessing any clinics. This recognizes the strengths rather than the assumed needs of clients. We know about ourselves. You don't need to coach us in our transition. Cheer us on, don't coach us. We know, unless it has to do with our actual healthcare, you don't need to tell us what we need to be doing in our transition. So a practice point is to reflect on your own identity and how it influences your professional practice. It's a good thing to start with. Reflect on yourself before your professional practice. Stephanie?
Okay, thanks.
Oh, this is one of my favorite quotes. Trans health and trans patients themselves must not be treated as an isolated education island of knowledge and practice. We are people. We access clinics for the same reason that cisgender people do. Also, get the knowledge, get the education. We need you to do it so that we can receive inclusive and respectful healthcare.
Great, thanks, Eli. And so let's talk about the trans project itself. The first thing I wanted to say coming into this is that we didn't find anything specific to cancer care. And the second is that the research on cancer care in trans people is really, really sparse, mostly because the stats are really, really terrible. But the thought is that the incidence of cancer may be higher among people who are trans and gender diverse than the general population. And it's thought that it's due to a combination of minority stress, increased alcohol use and smoking, an increased amount of survival sex, and decreased cancer screening. And so it's worth thinking about. So can I have the next slide, please? Thanks. So the timeline, we started way back in 2018 with assembling the research team. And I think it's important to look at how long this took, because doing this kind of community-based, community-led research is not quick. That being said, I'd really strongly recommend you not do it during a pandemic. That didn't help our timelines at all. But, you know, nobody told us there was one coming. We got our funding through the Saskatchewan Health Research Foundation and the Saskatchewan Center for Patient-Oriented Research. It was a Sprout grant. It took us a really long time to get ethics. And that was because it was a really complicated project with lots of moving parts. And because we really didn't want to limit who could interact with the navigators, and we didn't want to exclude anybody who didn't want to be part of the research from interacting with the navigators. And we didn't want to make the consent process so burdensome that people would just say, screw it, and hang up if they were in distress and wanted to work with the navigators, but didn't want to go through the consent process. So we probably spent 6 months in conversation with ethics to get ethics approval, but it was a really worthwhile process. So we'd ended up launching the pilot in April of 2021. As Elijah said, we ran for a year with the navigators, and then went into a really tense period of how we were going to keep funding them, and everybody dug into their pockets and their couch cushions and underneath their car seats and pulled out their nickels and dimes, and we rattled some cages, and we've got more stable for them funding. And so since they ended in April 2021, they've been running through this community-based organization, and we have been analyzing our data, writing papers, and strategizing our next steps. So the next one, please. And so we formed our team. It was started by a group of trans and gender diverse people, community-based organizations, healthcare providers, and healthcare decision makers coming together and deciding that there just wasn't enough healthcare, and we didn't know enough about healthcare for people who are trans and gender diverse in the province, and we needed research. And so Megan and I were shoulder tapped. Megan is a family doctor who does trans care in Regina to lead it. And so we specifically went about looking at the research skills we needed and shoulder tapping other researchers to join the team. But in terms of healthcare providers and trans people, anybody who expressed an interest in joining the team, we said, yes, please join us. So we hired a research assistant who did a literature review, another one who did an environmental scan. And so at last count, we've had about 36 team members over the time period. We've never had 36 all at once. And this adds up to more than 36 because many people have more than one hat. We've really focused on having as many team members as possible be trans or gender diverse, but at least be part of the 2S LGBTQ plus community. And engaging our community-based organizations so that we stay tied to the community. I think we've had more than 4 researchers, but we tend to have about 4 at any given time, and our 2 navigators. And so it's a big team. It's like herding cats because everybody's really busy. But the only real drawback is scheduling meetings. And so to schedule a meeting, we have to start about 2 months in advance to find a date that works for everybody. But it has a real strength because when stuff comes up in people's lives, there's always somebody else to take over. And so we've had, really big events in people's lives. We've had 2 team members die. We've had people have babies. We've had people get really ill. We've had people change jobs, some people more than once, and people come in and out of the project, but the project has kept moving steadily because the team is big enough for work to rotate around and people to take things on as other people have had to let things go. And that's been a real strength. So while most people will tell you a big research team is an encumbrance, we found it a real strength. Next slide, please. So the objective was to assess the impact of the peer navigators, and spoiler alert, they were wonderful. Next slide. What we learned, take time to build a team and prioritize their well-being. There's a lot of emotional work involved in keeping a team this big going and working well together, and that's really important. Commit to the community-based participatory approaches, listen to community first, center their voices. We listen to them first in meetings, asking them first, asking them again last. And when there's a discrepancy, unless there's a really good reason, like, because the funder says you can't do it that way. And then we figure out how to do it the way we want to, but make it look like we're doing it by the letter of the law. Really focusing on what community wants, really working on breaking down structural barriers. We've had real problems with university structures and bringing community in, but making that a real process. Focusing on language. One of the things within our team is that with having so many community members, they don't always understand what the researchers are saying. And the researchers don't always understand what the community members are saying because they're not up on the slang. I mean, I'm the first one to admit that I'm about 30 years behind. And because we've got researchers from such different disciplines, we don't understand what we're saying. And so being really aware and backing up and explaining, and we just make that a matter of habit and making sure that nobody's afraid to go, can you explain? I don't understand what you're saying. And as I said, acknowledging and addressing power imbalances. Next slide. We spent a long time developing the navigators' job descriptions and spent a lot of focus on that. So we started with extended discussions about team members' experiences as navigators, doing it informally. And we ended up with some real contradictions here among trans members of our team who had been informal navigators, and some real differences in priorities that we had to spend months discussing to come to a consensus about. Then we developed a working group to develop a prioritized list of duties, and all of our working groups have trans members on them. And when we know that we have divergent opinions, we make sure that all of those opinions are represented on working groups. We incorporated the results from our environmental scan into that. And then we decided that our most important thing when we were looking for our navigators was lived experience, and that healthcare experience was secondary. So the two navigators we hired, Elijah is trans man, as he's told you, and a medical office assistant, and our other navigator is also a trans man and a dietitian. But that lived experience was the most important, and that's come out in our research, that the navigators and their clients have all said, and the healthcare providers who have worked with them have all said that lived experience was essential. So I'm glad we got that right. Next slide.
I was just going to add, Stephanie, that this lived experience is really important, because in our work, we've realized that a lot of clients that we're working with have actually never met another trans person before, or parents that haven't met another a trans adult that's thriving and hasn't seen a trans person outside of media. So this lived experience was so important so that we can connect with our clients and so that they feel heard, and that it's not just going to stop at, okay, you're trans, you're my client, this is what we're going to do. So that, like, yeah, the job itself works on lived experience, which I'm so thankful for, with all that work.
Yeah. So I am going to skip this slide just because I'm going to go on and talk about all of these things one at a time, and I'm running short of time. So you want to go zipping along? So one of the first things we did as a side project was to work with the Health Quality Council and the big administrative health databases to see if we could use de-identified data from physician billing, hospital data, emergency room data, and pharmacy data to see if we could find a cohort of people we presume to be trans. And we did. And we found a cohort of almost 6,500 people, mean age of nearly 43 years. It was significantly larger and significantly older than the number of people who declared themselves as trans on the recent census, which is not surprising because we know that people don't declare on censuses because of being afraid of the consequences. We don't know why it's skewed so strongly male. We know that not everybody will have changed their gender marker in this system. So we know that that doesn't necessarily correspond to people's lived gender, but we still don't know why it's nearly 70% male. 75% of people made it to the 2 years post-index date. And the nearly 25% who didn't, they were only identified less than 2 years before we had our cutoff. And what we did, so the really cool thing is that we were able to do that. And then we found that as people report on surveys, their healthcare usage was significantly higher than the general population. And we're hoping to now use this to be able to study how their healthcare usage is higher and to use that for planning better ways to provide the healthcare that people need. Next slide. Navigator statistics. This was who used the navigators. The most important thing here in the dark purple is that the navigators saw nearly 260 clients, individual clients, and I use saw loosely because this was a pandemic, in the first year, and nearly 96% of them contacted the navigators more than once. So they wouldn't have contacted them again if they weren't really happy. Nearly half of the contacts were for information. Another 20% were for legal and gender marker changes, showing that that was really important. And then the next biggest thing was people needing family physician referrals. And that was the one where our navigators had the hardest time providing the service people needed, and that had no fault of their own. They would have, if there was a kit at the toy store for creating family physicians, they would have gone and mixed up as many as possible, but they couldn't do that. They had contacts from 70 healthcare providers, half of them made repeat contacts, and the vast majority wanted information. The others were education, so particularly like more formal education sessions or contact with a mentor. Next. Interview quotes. So we did post-service interviews with both clients and healthcare providers. So one client said, the experiences, the access to services, it has without exaggeration felt like I'm living for the first time. To say it changed my life might be the wrong term. It feels like it started it. Eli?
Yeah, and the next one, there was a sense of mutuality, which is really important in creating the healthcare and advocacy. And in advocacy stuff that I've gone to him about too, it's understanding what it is to fight for our rights, and he innately understands that.
And a physician said, almost all of my referrals are coming from him because so many of the trans clients don't have family doctors. I think it's really helpful for patients to have someone to reach out to because I don't know that they would be able to find me on their own.
Another healthcare provider said, information that I have is out of date, and that the navigators have that ability to keep up to date. I need to have an awareness, but I'm not going to have the fine details. The navigator knew the little details that help a person plan for their transition.
And a client said, it was nice to be able to have someone to talk that through with. It was a nerve-wracking experience.
Definitely has in a positive way. I feel more myself. I'm starting to feel happier and more hopeful, even in the face of the world. I wouldn't be this far along without all this help.
So the interviews just consistently said that the navigators were really helpful in a broad range of ways. So next slide. And this quote was completely not part of our research. My partner was taking a women and gender studies class, and the navigators just happened to come up in the discussion. And another student said, the navigators are a godsend. And so I have been using this one as a completely unsolicited freebie quote ever since. So next slide. So here are my recommendations for people, and most of these are from Squires et al. This is a study out of Saskatchewan and Alberta. The first two are their recommendations for clinical practice. The last four are for research, but I think they have clinical as well, clinical application as well. So the first is to create a welcoming environment. So be conscious in making sure that your clinic environment is welcoming for everyone. Prioritize trans and gender diverse education for healthcare providers. In your outcome measures, include psychosocial outcome measures. And this goes back to what Elijah said about not telling people that their experience is wrong, believe them. Needing cross-institutional collaborations. Nobody knows very much about cancer care and trans people at the moment. So this is where you need to use your good clinical judgment. Don't just automatically say people have to stop hormones. Work with people's other providers and use your clinical judgment. Consult and collaborate with community members, community-based organizations. Include intersectional questions and discussions. People come with their whole lives. People don't drop their lives at the door and become just blank slates with cancer. They bring their whole selves with them, all of their luggage. And my personal advice would be to engage your navigator, your social worker, your psych people, whoever you've got on your team, and work with people's other healthcare providers to provide as much person-centered care as you possibly can, so that people feel like their whole person is being respected. Next slide. So these are references for you. The WPATH Standards of Care, that's the World Professional Association for Transgender Health. These are the gold standard. The Canadian guidelines are the Sherburne guidelines for gender affirming care. Both are available free from those websites. Next. Here are some professional resources, including the new Queering Cancer one. The references we've used, including quite a lot of hours, just to toot our own horns. And some more references we
like to read.
Yeah, in case you feel like reading, this is our Instagram.
Yeah.
And then I think, yeah, this is where to reach us. So thank you very much for listening. And yes, we welcome your questions.
Great. Thank you for sharing your expertise and your insight with all of us today. That was a lot of great information. I'm going to just actually go to the first question. Can you comment on areas where you see the most need?
Family doctors, family doctors, family doctors, followed by mental health, mental health, mental health.
Yeah, anywhere that your government's taking funding from, that's where we need the most.
And sexual health education, sexual health education, sexual health education. Yeah. Really basic stuff.
Okay, so we also had questions that came in before or at the time of registration. So I'm going to just maybe pose a couple of these questions. So how can we best engage transgender people in evaluation of health services when they make up such a small number of clients or their patients?
I think that people assume that we are such a small number, but there's a lot of people that will not tell you that they're trans. You're not going to be able to tell if someone's trans just by meeting them in person. And the way to better things is to include us in these conversations. Cisgender people are not going to have the same experiences as us, and are not going to understand our experiences as well. So including us and compensating us for that work, which a lot of it can be trauma-inducing, so that's why I say compensating us, that's how you're going to make your spaces better and safer, and how you're going to learn more is, like Stephanie said, that lived experience is so important. So include us in those conversations, because otherwise you're just going to be assuming things that could be incorrect.
Great.
And I'm going to
Okay,
put on my researcher hat here. And I'm going to say, get involved with the community and ask them what they want to know. Do things from a community-based approach. So don't go in and say, I want to know this about you, because they have every right to say, bugger off, we don't care, and you're being a nuisance, or something much stronger. But go in and say, build those relationships, get that trust, work with community-based organizations, include the community-based organizations and trans individuals on your team, oversample so that you have enough voices, and exactly compensate people, and compensate people fairly for their time and expertise. Lived experience is true expertise. It's not nothing. It's not, yeah. So it's taking a very different research approach. You can't come in as the great scientific savior.
great. Thank you so much, Dr. Madill. We have another question. If the healthcare provider doesn't know a person is trans or gender diverse before speaking with them, how do they recommend the HCP ought to respond? What should they say? How should they react?
Hi,
Like
my
I
name
said,
is,
go ahead,
my
Stephanie.
pronouns are, and if, then that gives the person an opportunity to tell you their name and their pronouns. And then you go, thank you. And you carry on like normal. And you school your facial expression, and you be surprised later.
And like, humanize yourself.
Yeah.
In order to get to know your patients, you have to humanize yourself so that they can trust you. Don't expect that just because you're a healthcare provider that someone's going to trust you, especially if someone's trans or gender diverse or two-spirit or indigenous and trans. We've had, and BIPOC and trans as well, I guess I should add that as well. We've had some pretty tough experiences within healthcare systems because of the way that the historical oppression that the system has caused upon us. So you really just have to humanize yourself. Don't treat us like another patient. You should be doing that for every patient that you're encountering, so that they feel comfortable enough to tell you about why they're seeing you. Not everyone's comfortable telling a total stranger what exactly is going on with their body, especially if it has to do with their genitals. So humanize yourself before expecting someone to unload their whole identity and healthcare issue that they're contacting you about.
Yeah, and be prepared for people, as anybody does, to disclose in stages as they become more comfortable.
Perfect. Thank you so much. So we have another question. We were encouraged to state our pronouns to make people more comfortable. Are there any other suggestions?
Pronouns are a good start. I think having resources and information about nonprofits within your whichever province you're within can be helpful too. Making sure that your space is a safe space. Make sure that all clinic staff are getting this education, not just doctors and nurses. Make sure that your MOAs are getting this staff. I'm an MOA. I know that most people aren't given the education that they deserve to be the first person that a patient sees at that clinic. So making sure that you're getting education, having resources, and up-to-date education. Just because you take one session does not mean that you're up to date. Constantly be getting your education. Things change, and things change so rapidly within the healthcare system. So it's important to keep up to date.
Yeah. So, make sure that your posters represent a wide variety of people. Make sure that if you have done safe space or safer space training, that you have safer space training posters up saying that you've done that, or pride flags and trans flags. But if you haven't done the training, don't put the posters up. As Elijah was saying, you know, make sure your medical office staff have them up. You know, I finally got my medical clinic staff trained to not ask about people's husbands and wives, and then they changed staff and I got asked about my husband, and I don't have one of those, and so now I have to work on them again. And so it's that continual process, because staff changes, you know, there's a new issue du jour. It's making sure that it becomes routine and you just become comfortable with it. And quite frankly, you know, get to know some trans people and some queer people as friends, and just become comfortable. Go to some protests, have it be something that's part of your life outside of work, so that it's not just a work thing that you're having to remember, but it's just part of your life that you've assimilated.
Yeah, and also take complaints and criticism seriously. If someone's contacting your clinic to be like, this was really uncomfortable, this person wouldn't call me by my name, wouldn't call me by my correct pronouns, take that seriously. I find that a lot of like healthcare staff will be like, well, it's not legally changed. That doesn't matter in EMR systems. All people need to know is a health card number for billing. Yeah, take those things seriously and make sure that, just because, like, education, that's just the most important thing here, is that education and getting consultation from the community, but a diverse group of the community, not just being like, well, these two trans people said that this was okay. Two people can't speak for the whole community. I can't speak for the whole community. I'm a trans man. I don't know the experience of a trans woman or a two-spirit person or anything like that. So you need to make sure that you're doing this with a diverse group of people.
Mhm.
Great. I just want to thank both of you once again, Dr. Madill and Elijah, for being here today with us. Unfortunately, we've run out of time. We want to be really mindful of everyone's time. I'm sure that we could go on and on another half an hour for questions, but we just don't have the time today. Thank you once again. If you wanted to just advance to the next slide, please. I just want to remind everyone that we are here for the blood cancer community. Do not hesitate to order our tear pad for free, or contact us if you need more information or support. And just also know that there will be a short survey sent out to all participants after this webcast. We would greatly appreciate you taking a moment to fill it in, as it'll help us to offer you the most valuable information soon. Take care and have a wonderful day, and thank you all for joining us.
Well, thank you.
Thank you.